on that, Dr. Martin.
Well, thank you everybody for being here today. I'm Nancy Martin. I'm soon to be the medical director of the PES at UNM. And I have some experience with adults on the autism spectrum disorder. And so I wanted to speak with you all today about how to best approach these people in different scenarios that you might encounter. The entirety of my 4th year of residency was spent working with these patients through the Emory Autism Center, and I'll talk a little bit about that. But I'm not an expert. I haven't done specialized training in this in terms of board certification. So if there are questions, I'm always happy to take those and take them to people who have more expertise to me. So with that.
You might have to click on the background. Sorry.
So this is my disclosure page. I don't have any disclosures. I'm not working with the industry at all. In terms of learning objectives, we're going to define autism spectrum disorder and how that definition has changed recently with the DSM that we currently have, the DSM-5. We're going to discuss characteristics and needs of persons with ASD, and I will refer to it as ASD. And then reviewing strategies for working with persons with ASD, considering maintenance of officer and community safety. And so why should we in law enforcement care about this? Well, again, so I think maintaining your safety when you're out in the field, and then community safety for both patients who may be on the spectrum, but other people as well, is really important. Avoiding litigation, obviously, and then in general, making your job easier, because we all know you have the most difficult job, and these sorts of patients have different needs, and so hopefully we'll be able to clarify some of that today. So what is autism spectrum disorder? Well, it's a biologically based neurodevelopmental disorder that's characterized by impairments in 2 main areas. So there's the social interaction and communication piece, and that's both verbal and nonverbal issues, and then repetitive, fixated behaviors and restricted interests. So as you can imagine, that's a pretty broad definition. And so to be diagnosed with ASD, it's a complex interview that often involves both psychiatrists and psychologists doing a number of tests, and frankly gets missed quite often. So, but those are the 2 main areas that you're going to see deficits in. There are complex behavioral and neurologic along with genetic features to this spectrum disorder. And there can be executive functioning and independent living deficits, certainly. So autism spectrum disorder, it's basically an umbrella term for these complex disorders. It used to be called a number of things. It could be called Asperger's, which was basically the referral of somebody who's functioning higher on the spectrum. But then a number of other genetic illnesses that go along with ASD were kind of grouped into that. And so the DSM-5 now refers to everything as autism spectrum disorder, which I think is really nice because it would get confusing for some people. So there is a Dr. Stephen Shore, who's a professor in the country, and he's a higher functioning on the autism spectrum disorder. And he talks about something that I think is pretty, I like to talk to the residents about it. There's no one person who looks like they have autism. And so oftentimes residents will come to me and say, they look funny, they look like they have autism. Nobody looks funny and has autism. Everybody who has autism looks like the rest of us, unless there's some genetic component to causing their ASD. So this professor, Stephen Shore, says when you've met one person with autism, you've met one person with autism. So you're not really going to be able to see anything out in the field that's going to clue you into it. It's going to be these 2 areas of impairment that are going to help lead you to that, or maybe think about that diagnosis. So persons with ASD can suffer from intellectual disability, but that's not always a component of the disorder. There can be difficulties in motor coordination and attention, and then some physical health issues, for instance, seizures or GI upset. Like I was referring to earlier, there are a lot of genetic illnesses that go along with ASD or cause ASD. The most common one is something called Fragile X syndrome. It's the most common single gene component that causes ASD, but there's also a number of others. So deletion in the 15q chromosome, tuberous sclerosis, and then some other rare genetic abnormalities. But this is a complex illness, so it's not always genetically, there's not always a genetic, and most often there's very rarely a time where you can identify a genetic abnormality. Genetic testing is expensive, and if insurance won't pay for it, or maybe we'll just pay to see if the patient has Fragile X. Oftentimes patients and their families don't know what's causing autism spectrum. Okay, so why is this important? Well, Autism Speaks, which is a huge advocacy group for autism spectrum, has put together this data in combination with the National Institute for Health, looking at the prevalence and how it's changed over the years, even from as early as 2004. So it was about estimated one person in 166 to now in around 2014, it was 1 in 68. And so, you're looking at the darker blue shows you the prevalence, and then the lighter blue showing you the total number of persons that are living in our country with autism spectrum. And so it's the fastest growing developmental disability in the United States. And so we're going to see more and more of these people, especially as they age out of programs. There's a lot of funding, there's a lot of support for children who are on the spectrum. And as they age out of those programs, we really don't have the infrastructure in our country to support adults on the spectrum. And so I think interactions with law enforcement professionals will become more common. So this kind of speaks a little bit more in detail about the epidemiology. So the prevalence, 1 in 68 children. It's more common in boys, so it's about 1 in 42 boys and 1 in 189 girls. And there's a lot of suggestions around that. Like I was referring to earlier, Fragile X is one of the most common reasons for somebody to have autism when it comes to a genetic abnormality. And oftentimes, because of the way that illness is inherited, that affects males more often. So that skews this data a little bit, but that doesn't 100% account for all of the reasons why there's more boys than girls. Research is still trying to answer that. Okay. So let's talk a little bit about each of these areas of impairment and what you might see. These are not something you're going to get this whole list, and somebody on the spectrum might have all of these. They might have one of these. So it's kind of it's going to vary from patient to patient. But like I said, there's nonverbal or limited verbal skills. Most of the time, or it's around 50 to 55% of autism spectrum disorder patients that they are not verbal at all. So that's one of the first key signs that we see as physicians if there's a delay in speech. There's this avoidance of eye contact, something called echolalia, where phrases or words are repeated, or there's repetition of body language. So things like hand flapping, spinning, other sorts of repetitive, non-purposeful movement. A trouble relating to others in terms of social situations. Difficulty on how to read facial expressions. So for a person who has ASD, recognizing that somebody's sad or angry is not something that they're easily able to do. Whoops, I have that on there twice. Avoidance of eye contact. And then aversion to physical touch as well. So that these people sometimes have grossly paradoxical or opposite reactions to maybe receiving a hug, whereas somebody who's not on the spectrum might very much enjoy that. And then they often prefer to play alone, and they don't want to play or interact with others. So those are the main things when it comes to social interactions and communications that you might see. We'll go into specifically how that's going to affect how you interact with persons who might be on the spectrum. Some of the behaviors that you might see. So the display in tantrums or extreme distress for no apparent reason, or apparent reason to us. If you're not on the spectrum, you might not understand why they're having a tantrum. This insistence on sameness, so wanting things to line up, wanting things to look symmetrical. That's what I mean when I say insistence on sameness. Inappropriate responses to sounds, lights, or touch, both in the hypersensitivity, not liking those things, but also maybe being attracted to them and overly attracted to them. Again, I put avoidance of touch on there because I think it's pretty important for both social interactions and their behaviors. This sustained, unusual, repetitive play. For instance, some of the kids that we see who are on the spectrum, spinning of things can be a very repetitive play for them, and so they'll spin a plate for 2 hours, and that can be an indication, that they might have ASD. Inappropriate laughing or giggling, inappropriate attachment to specific objects. Fascination with water, lights, and reflections, and that'll come up when we talk about the types of calls you might receive with somebody who's on the spectrum. And then again, this echolalia, this repeating of words and phrases over and over and over, almost like they love the way that a certain sound creates when they speak it. And then I already alluded to this: the spinning objects or themselves, hand flapping and rocking. Okay, so those are the most commonly observed behaviors in those two symptom domains. There was a film that was done by two Ringling College students, and it was featured in the New York Times, and hopefully we're going to get this to work. But it won a 2014 Adobe Design Achievement Award, and it basically combines in an animation form how a nonverbal child with autism and sensory sensitivities might experience the world. And I think it's short, but I think it's pretty clearly indicative.
Thank you so much for coming. We've had a really rough week.
Don't worry, it's gonna be okay. Hi, sweetie. How are you today? Today we're gonna play a game, kind of like the games that we played at school. Look what I got you. I know how much you like animals. Do you see this? This is a cat. How does a cat sound? Meow, meow. And look at this card, Lovey. This is a dog. How does a dog go? Woof, woof. Can you try to match these cards for me, please?
No, what dogs?
Hello? This is her. Yes? I'm really sorry. What? What do you mean she can't return? Where else are we supposed to go?
Will you focus?
I don't know. It's too loud.
Stay with me. Let's look at this new set of cards.
Too loud. Just be
Can you
quiet.
match them for me?
I don't know. No.
It's okay. Lovey, this is okay. Look what I have for you. Look at this. I know how much you like this.
Quite creepy.
All right. I hope this doesn't. Okay, so we can send that link out for anybody who wants. It's the title of the film is called Listen. It's available on YouTube. Anyway, I think it's a really well done short version of what it is to experience this overwhelming sensory stimulation for a person who's on the spectrum. That even the smallest sound that you and I, would experience and not think twice about. Number of behaviors that we've talked about. And so one of them, oftentimes that I've heard from patients, is the sound of the air conditioner or the sound of a phone ringing, like you heard in the video. Just these small, or the sound of a train going by outside can be so overwhelming that they cannot continue with their thought process. So I think it's really important to kind of show what it's like for them. So I referred to this earlier, and some of these things you might see as well in the field, but I thought would be good to spend some time on. So this idea of hypersensitivity or hyposensitivity, and it's not clearly one or the other all the time. So in terms of senses, a lot of patients who are on the spectrum dislike wearing certain articles or types of clothing, specifically wool or anything that's really scratchy. The dislike of being touched, this overwhelming sense of sight, sound, smells, or tastes, difficulties with sense of movement, so that they're more prone to falling down the stairs, tripping on things, and then difficulty with fine motor or motor planning activities. So I bring that up because some of these people, you could imagine how it might look like they're impaired, might look like they're drunk, whereas, it's really that they have some difficulty with their motor movement. We talk a lot about the deficits of people who are on the spectrum. I think it's really important to talk about the tremendous strengths that these patients have. Some of the most brilliant people in history have been thought to be on the spectrum. And so one of them is this strength of visual skills, and quite frankly is a very interesting area of brain research in my mind. And we'll talk about a couple of specific examples, but almost the ability to have a photographic memory. Memory of details, the ability to focus. The special interests often lead to them becoming experts in certain areas and not having any education in a specific area or field, but becoming very, very proficient in them. This above average intelligence. So again, I really want to make the point that patients who are on the spectrum, sometimes they have seizures, sometimes they have problems with their GI system, and sometimes they have intellectual disability, but most of the time they don't. These people are they're rule followers. They want to follow instructions that are told to them. And people on the spectrum have a hard time lying too. So it comes out, they're very honest people, and problem-solving ability as well. So I bring up a couple of examples. This man is called the Human Camera. His name is Stephen Wiltshire. He's a very interesting guy. That's his sister. He lives with his sister who's behind him. And he's capable of taking a helicopter trip above a city and then reproducing the entire skyline from memory. And so he's done this with almost every city. This is New York. He's done one, Mexico City, he was able to reproduce. National Geographic just did a piece on him, and they have a video as well. It's fascinating, and he's made a living out of this. So, I mean, you can imagine the people would pay a lot of money for this sort of artwork, and this is how he supports himself. And then I'm sure many of you are familiar with Temple Grandin. She's a woman who's on the spectrum who, if you know anything about farming, she invented the cattle chutes that basically help farmers who, to produce milk and produce beef, help them get cattle going through a certain area. I don't know a lot about farming, but this is her original drawings. And she used her knowledge about how she prefers to be in tight spaces as somebody who's living on the spectrum. She likes to sleep in tight spaces, and so she was thinking about how maybe the animal would feel most calm. And from my understanding of farming and cattle farming, that when they're trying to put an animal through a certain area, unless there's that tight space, there's a lot of opportunity for the animal to become anxious and try and move backwards. And so she was able to really revolutionize this area, and did so very successfully. So she goes about the country talking about her experience with being on the spectrum. She's written a number of really excellent books, if anybody's interested. So I really want to highlight the fact that there's a lot of positives about being on the spectrum. Now, when it comes to comorbid issues with mental health, there's a number of them. So of course, like any other person, people who are on the spectrum can experience depression, anxiety, obsessional thought and perseverations due to the nature of ASD can occur more often. Anger management for not feeling understood or being able to deal with certain environments can occur. Emotional coping skills can become an issue, stress management, and then loneliness. So all those things happen. It's not uncommon for us to see patients who are on the spectrum who also have a primary psychotic disorder like schizophrenia. There tends to be a lot of overlap in them, and so psychotic thinking can sometimes be accompanied with these patients as well. Okay, so when it comes to what you all are seeing, what's most typically what you're going to interact with or see or hear? So like I referred to earlier, persons with spectrum who are on the spectrum, they often appear, they look, perfectly typical. They look perfectly normal. There is no look unless they have a genetic abnormality that's causing them to have a dysmorphic face or, some facial features that look different. There's no way that they're going to look. They may not respond to a typical command that you might give them. We'll talk a little bit more about that. And they actually may attempt to move or run away when approached because of that aversion to being touched. They may cover their ears or look away from you. They can have difficulty with eye contact or feeling overwhelmed with sensory stimuli. They might have the motor skill problems that will affect their gait and make them look intoxicated perhaps. And then they may display unusual or repetitive physical movements with the rocking or the hand flapping. We might see this as well. Okay. So what are the calls that you're typically going to get? The most common ones for assistance are going to come in terms of missing persons. So 49% of children on the spectrum elope at some times. They wander. They might see something that's really interesting to them and they leave, not knowing some of the consequences that might come with it. I mean, children who aren't on the spectrum do this as well. 1/3 of those patients aren't able to communicate their name, address, and phone, which is pretty terrifying. And then 91% of deaths related to wandering with persons on the spectrum is caused by drowning. And that's more related to this, patients on the spectrum really go towards water, towards lights in some ways. And so they'll go towards a water source, not knowing the danger of it, and end up drowning. Oftentimes there's odd behavior on another's property. So again, knowing that social boundary of this is not my property, I shouldn't sit on this, doesn't really apply to, somebody who's on the spectrum. So somebody may, somebody on the spectrum might be trying to gain access to a home or sitting outside on a swing. So you might get calls about that. Splashing in water fountains, like I said. The swings and the slides more about that sensory stimulation for them. And while that might be normal for us to see children in a playground swinging or sliding, it could be perhaps distressing to parents of children to see an adult person who has autism spectrum doing these behaviors, and so you might get calls about that. Oftentimes there's that need for order, and so there are typically calls about somebody who's on the spectrum making order of, in a grocery store, if there's a display where things are backwards or not in the way that they want them, you can imagine that might turn into this person's trying to steal something. You might get called about a shoplifting complaint. And then again, the missing persons. International border inspections, airport, any sort of building or event security checkpoint, those are areas where persons who are on the spectrum might have difficulties. And you can imagine too, the presence of K9 partners at the security checkpoints would be distressing as well. So these are the typical calls that you're gonna get. So we'll talk about ways that you can maybe alter your response if you suspect or know somebody to be on the spectrum. So like most things in medicine, we use an acronym for it. And so this one's autism. So we'll just start with A. With the approach, you want to approach in a quiet, non-threatening manner. You want to avoid quick motions and gestures that might be perceived as threatening to these people. To understand that they, very much want to avoid physical contact. So I'm sure this is one that you all don't do very often, but I'm not touching the person on the head or the shoulders. That would be really important for them.
It's frowned upon.
Yeah. And then talking, you want to keep a moderated, calm voice, keep your language very short, simple, and concrete. Know that you might have to repeat yourself and allow some response time. The other thing in this is that persons on the spectrum really struggle with metaphors and slang. So things like saying, do you think that's cool? Or what have you got up your sleeve? Things that you and I might say to each other and understand, people who speak English as a primary language might understand. This is really difficult for persons on the spectrum to understand and make sense of. And they take things very literally. For instance, I had a patient, my 4th year, who didn't get the concept. He was on the spectrum and very intelligent, but could not understand the differences between up, above, below. He didn't get that concept. And so you would have to really be specific with your language and speaking with him. So if you all were to say like up against the wall, you might imagine how it would be pretty confusing for somebody who takes that literally, okay? So you want to try and avoid that slang in general. And so to give you some examples of this, we've got a couple of Australian slangs. Who's got a very good Australian accent? I think Matt. Matt, can you?
I'm just gonna completely,
It's okay. Try it.
Did you put the tags in the boat?
Nice. That's
more
That's
English.
good.
That's not good, mate.
Perfect. That's perfect.
Did you put the tags in the boat?
Wow. No, keep going.
Let me just make any other countries or races or something.
Just do whatever accent you want.
That's pretty good. So what do you imagine that means, Matt?
I have no clue what a tag would be. Like
The
your
top?
Tog.
Tog?
Togs.
Oh,
Are you the
Togs in the boat.
yeah. Did you put
The boots.
in the?
In the boots.
Yeah. I would
Your
think
feet?
just your tongues of your shoes, maybe.
Okay.
Going back in the boot.
Okay.
Good.
How about this one?
That's it. One's easy.
You want to read that one?
Yabbies have snags for tea.
There we go.
Wow.
It's getting better. It's
Hit
getting
it.
better. Okay. What do you think that one means?
That means like, do you want yabbies or snags for tea? It's pretty self-explanatory.
Okay. And this is the last one.
Whose turn is it to shout for ice cream?
That's perfect.
Yeah,
They got
wow.
better as you progressed. What do you
Australia.
I think she's being really nice.
Get a tour of England over there.
I appreciate your participation. What do you think that last one means?
Who's gonna order ice cream?
Okay, so it's interesting to me that rather that you provided an answer before you actually really even knew, rather than saying I have no idea, right? You wanted to give an answer. And so this really speaks more towards when you're interviewing somebody on the spectrum. We're not going to go into that today, but how this is how some of these metaphors that we don't think about, this is how they sound to persons on the spectrum. So that first one is, did you put the bathing suit in the trunk? That's what the togs on the boot are.
Huh. Did you put the bathing suit
In
in
the
the
trunk.
trunk?
Yabbies or
They
snags
have
for
a whole
tea.
phrase for
Mhm.
that.
Yeah. Yabbies. Yabbies and snags is shrimp or sausage for dinner.
Do you know which one is which?
I think shrimp is yabbies. Yabbies and snags for tea.
Well, you got it.
Hey.
And then this last one, whose turn is it to shout for ice cream? Whose turn is it to buy the ice cream?
Well, you got that one. 1 out of 3 is good.
I know how to order ice
Practical
cream in
Australia.
Australia.
It's English.
No, guess that wasn't English.
Okay, so getting back to our acronym. So the S stands for seek. So you want to look at, all indicators to evaluate the situation as it's unfolding. I know you all do that anyway, but be willing to adjust your actions accordingly. So for me, I had a patient come in to our emergency room when I was working in downtown Atlanta, and I knew he was on the spectrum. He was brought in by his father. And we have a very, set way about how we interview somebody, and typically involves a nurse going to do the triage, and then myself and, maybe some other health worker coming with me to interview them. And this person was so agitated, one, because he was in this tiny little room, which might not have been distressing to anybody else. It was very distressing to him. And he was rocking, and he was doing a lot of hand flapping, a lot of behavioral issues. He could not sit down to talk to me. And his dad told me he really likes chips. And so I went and got a bag of chips for him, and he was able to sit down and talk with me a little, enough for me to do an evaluation with him. And so you have to be willing to adjust your actions. I don't buy chips for every patient I see. It's just not something that is part of my protocol, but you have to be willing to adapt your actions accordingly with these sorts of patients. And then visually evaluate for injuries with persons on the spectrum, because oftentimes they're not able to communicate them, or they're not able to ask for help in this way. So your role is very important as a first responder. And then finally, maintain. So keep a safe distance until appropriate behaviors lessen. So if you come to a scene and there's somebody who's having behavioral disturbance, don't try to stop it. Oftentimes patients who are on the spectrum need to have some sort of outburst, whether it's verbal or physical, and keep that safe distance until the behaviors lessen. And then remain alert that impulsive behaviors or outbursts can occur at any time as well. Okay. So this kind of summarizes all of that. If you're approaching in a vehicle, avoiding using lights and sirens. I know this has been mentioned with other patients in different areas, specifically with persons living with traumatic brain injury, but this is the same sort of thing as that sensory overstimulation. Okay. So there's these cards that a lot of states will provide, and it's a nice way, given that so many persons on the spectrum aren't verbal, and should you encounter them in a wandering situation, if you're in contact with families or persons on the spectrum, I would encourage you to encourage them to get some sort of ID. So whether that's a personal ID card, a medical ID bracelet, even safety tattoos. But these cards are issued. I know it's a little extreme, but
What is a safety tattoo?
it basically saying I have autism spectrum.
Really?
Yes.
This is a real thing?
Yes. And obviously it's people who are able to consent to that sort of thing. But this card does just the same thing.
It's a lot of knuckles.
There's
That's what I'm wondering, like, become a autism.
And so every state has different ones. I know that in Massachusetts, they issue instead of a driver's license, they'll do an autism license as well that has the picture and has an address and has a phone number, which is nice. That typically a physician has to fill out a form saying that the person has autism spectrum disorder. But these are available online, and there's a reverse side that basically has something that you can fill in a name and an address as well.
Sorry to interrupt, but so are you guys still passing these out? Because you were, right?
Yeah, we still make these a lot for people with autism.
Oh, do you?
Mm-hmm.
That's great.
And so like if you identify, sorry, this is Dan Duhigg. If you identify that somebody has autism spectrum disorder, you just kind of, you ask them if they want it, you give it to them, and you teach them how to present it to law enforcement or the first responders. Okay.
We give them just a little kind of like a tip sheet on how to present it. Like, we don't want people, especially if someone has a flat affect or odd behaviors, just be reaching in their pocket the moment they see a cop.
Right. So
know,
so what do you teach them? What do you prompt them?
Just that to ask officers, can I show you an ID, or can I show you
I
something?
can show you my card. Okay.
And we say to keep it like in your wallet or a normal place where you keep an ID, or wear it around your neck if you want to. If someone's really bad. But this is also, you have to have someone that's lived with autism that's willing to share that
To
too.
self-disclose.
That's what I was kind of surprised about the tattoos. Because a lot of times people, what I've noticed is, well, maybe it's not autism. It's really popular with autism, especially with children. But other major mental illnesses, it's like people have the stigma. I don't want to be card-carrying member of having an illness.
Mm-hmm. I think this one's mostly important, and I can imagine it happening more often in patients who are not verbal, for their family members to have something that can identify them if their caregiver wasn't there with them, to help guide the persons interacting with them. What questions just have come up?
Does it have your slides?
Just do.
Oh, sorry.
I guess I should probably do those if I was going to answer questions too.
Javier had a question. He says, how young can you diagnose? How young can you diagnose someone with ASD?
Yeah, that's a really great question, and that's a changing response. So right now there's a lot of really interesting work going into infant work, looking at eye tracking and trying to see if there's an association with persons who are later go on to be diagnosed with autism spectrum and difficulties with eye tracking. So I know at Emory University they're diagnosing with this study as early as 6 months. For most people, you're going to start seeing deficits in language communication or physical abnormalities as early as 2. But like we were talking about last week, there are a lot of people who are going undiagnosed for until adulthood, and those are obviously people who are higher functioning on the spectrum. So it's a wide range, but there's really interesting research going on right now about infants.
I don't know if there's any questions.
Do you think that the
Can you announce yourself?
Lawrence Savedro with APD? Sorry. Do you think that, like, when you were talking about your statistics and you saying that the amount of people with it is going up, do you think that's because we can identify it at 6 months, or
It's a great question.
or is it both?
It's both. It does not. So our increased recognition and diagnosis, and then the expansion, I think, too, of what is autism in terms of a diagnosis, does not account for the increase in prevalence. So there is something else going on. There's no evidence to support that vaccines cause autism.
That's good to say. Yeah, it's been like
There is zero evidence. In fact, the evidence that came out that supported that claim has since been, it has come forth that that data was all made up, and that person's lost their license. So. But we don't know. I mean, we just don't know.
We get that a lot. I have a question, Matt Tim with APD. Because I'm sure this comes up in medicine, but if we have to go hands-on for whatever reason, like a safety check, a pat down, or to arrest somebody, so it involves a physical contact. Do you have any tips on that? Like, should we explain what we're doing, or should we? Sometimes in law enforcement training, it's more of a surprise tactic if someone's acting odd.
Yeah, that's a really great question. Please pipe in anybody else who's had, most of the time I'm seeing the person after they've been brought to the hospital. But in my experience, I think introducing yourself and saying what you're going to do is the best thing with patients on the spectrum. Now, there are times with behavioral outbursts, so it's not going to matter. You're going to just have to do what you need to do to make sure the person's safe, to make sure the officer's safe. But I would imagine clearly and very simply communicating what you have to do would be a good way to start.